Morning, afternoon, wherever in the world you are. I am Matthew Holt, and this is episode 99 of the THCB gang. For those of you who are joining us from the Primary Care Transformation Summit, we are really thrilled to be wedged in there and have a bit of a flavor of our weekly live video and podcast that happens on THCB gang. Normally happens on Thursdays at 1 p.m., but thanks to Peter Grant and his team there, we're looking forward to joining you all and having a bit of a chat. We normally talk about anything and everything to do with healthcare in the week. And this week, we're going to focus a little bit on primary care. And thankfully, our friends at Amazon One Medical gave us something to talk about. All right, let me tell you what I have on the gang. Normally, we have 5 or 6 people. Because we're a little bit shorter this week, we're going to only have only be 4 of us on. I'm the founder and publisher of the healthcare blog. You can find me at Boltyboy, making noise on Twitter. Talk about other noisy people. Jessica DaMassa is the my co-host of our Health Tech Deals show, but also the host of WTF Health, where she interviews almost anybody who is anybody in the healthcare innovation, funding, and new company space, and has some interesting thoughts about how that's all playing out. And then we have 2 real experts: Jeff Goldsmith, legendary health futurist, chairman of Health Futures Inc., who's been observing and forecasting the U.S. healthcare system and all aspects of it for a long time. I won't say how long, Jeff. And Dan O'Neill, who is probably one of the greatest followers on Twitter. If you're not following him, you should, at DP O'Neill, who seems to find out more about what's going on in the real world of American healthcare than almost anybody else, and is always digging in deep. And these days is actually working at a primary care company called Pine Park Health. So that's it. We will now kick it off, and we will start our discussion. We've got about 40 minutes to dive in and have some fun. Right. So I'm going to start with, we normally go around and ask people what they're up to this week, but instead I'm going to start and say, okay, so start with you, Jeff. Primary care, we're in a primary care transformation summit. Primary care has been transforming, as has healthcare, for a while, but you've said on this gang and many other places, been somewhat cynical about the ability in which payment systems and primary care has transformed. So could you tell me where you think we are in transformation, if there is such a thing, given all the activity, funding, new companies, and big talk about value-based care and primary care?
Well, I'm one of those people who believes that we need a wholesale change in the model for delivering primary care and a payment system that supports that wholesale change. I've been pretty much for 20 years an advocate of junking fee-for-service payment for this service. There just is not enough. There's not enough to hook all that payment system overhead onto without destroying primary care. And that's basically what we've done. We've ruined this part of our healthcare system by insisting on paying per incident of service. So when you began seeing new business models that were variations on a subscription model emerge in this space, I was like, right on, let's do this. That's been almost a 20-year project, and I haven't just talked about it, I've invested in it, I've advised it, pretty much since 2005. And I'm just like, I don't think we're there yet. I mean, I'm bewildered by the amount of sheer innovation that is taking place in this space. But I think we're still a considerable distance from proving the business case for subscribing to primary care services. And I think the Amazon One Medical deal kind of highlight a lot of that. One Medical is an elegant delivery model with a phenomenal user interface, happy customers. They have so much going for it, but in 15 years had not proved that they were actually a business. And one of the things I said in one of the interviews about this was, well, now they don't have to. Now it's up to Amazon to prove that direct primary care paid for on subscription is a business. I'm still not convinced there's a business here.
Fantastic. Dan, I want you to do 2 things in your interest section. One is say it's been a while since you've been on the gang, so A, welcome back, but B, tell me a little bit about your new business, because you've been in both the research capacity and also the business capacity in a bunch of tech firms and elsewhere, but now you're actually in a care delivery organization. But also, you were one of the first people to really dig into the One Medical business model, which is not, I would say, now they also purchased IORA, which is, but it's not the kind of what Ian Morrison used to call the capitated integrated communicated medical group system that we mythically were all going to go to. So tell us a little bit about what, and you have a great tweet stream from a couple of years ago, which I referenced again. I think my tweet was, whenever you say something clever about anything, Dan said it 2 years earlier and better. So tell us a little bit about how your assessment of the One Medical model, and then somewhere in there, tell us what the whole Pine Park Health is.
Of course. Well, first of all, thanks for the invitation. It's good to be back. I appreciate the invitation. And I think you've got firmly established OG credibility on these topics, Matthew. So you're safe there.
We're here with the really original OG in the other corner. So
there we go.
I'm still a young man.
There we go. Still now. So I've been with Pine Park for a little bit less than a year and a half. Pine Park Health is a value-based primary care group that delivers on-site or in-home primary care for residents of senior living communities. We go in and embed the primary care services within those communities and then serve residents in their homes. And we do that to the greatest extent possible under value-based or risk-bearing agreements with CMS programs, with CMS itself, or with Medicare Advantage plans. And then I think to your point on One Medical, I've been a One Medical member. I agree with what Jeff said, and I think what you've said, which is it can be a good experience. To some extent, that is probably a reflection of how low the bar is. So I think some people are delighted by One Medical because they can reach somebody asynchronously or remotely when they need a prescription refill or something very tactical, which is not a particularly high bar for patient service, but also a bar that the rest of the healthcare system often fails to meet. But regardless, One Medical has delivered, I think, and continues to deliver a pretty good patient experience in most cases. The flip side is their financial model, I think we've all sort of clearly established at this point, is very much about sort of exploiting the pricing arbitrage and leverage opportunities that the rest of incumbent healthcare providers have long done. So there's really, in some ways, very little that's innovative about their financial model, but there might be quite a bit that's innovative about their patient service experience, IORA being an exception here. To try to sort of see it fairly, I think it's hard for commercially oriented or primary care organizations that are oriented towards the commercial population to build a primary care business, a value-based primary care business in the same ways you can do in an older population, simply because the baseline health is so high. It's hard to move the needle.
Yep.
Many commercially insured patients just aren't going to the doctor very often. They don't go to the ER. They don't have major issues. And when they do have an expensive issue, it's often unavoidable. It's the rare cancer diagnosis or the NICU baby. There's nothing you can do about that in primary care. It's older, more chronically ill patients where there really are needle moving opportunities. And so risk structures make more sense.
So Jess, you spend your life looking at new stuff and new deals and new people. Obviously, you've talked to a lot of the players, both on the tech side and the people building what you call technology-enabled primary care services, as well as people selling technologies into them. What's your take on? And we had a bit of a chat on the health tech deals which came out this morning. But what's your take on Amazon One Medical? And then I want you to tell me a bit more about what your sort of take on this whole sector and how it's changing around.
My take on Amazon and One Medical. Well, I mean, I guess I love what Jeff is asking about the subscription model and whether that's a good business model for primary care. And so I think that's really interesting because what does Amazon deal with a lot? It deals with subscriptions. So it'd be interesting to see what else they start to vertically integrate. I think, to go along with what they've already got. So, I mean, they've already got telehealth, they've already got a virtual pharmacy business, they've got PillPack that provides delivery, they've got Prime, they've got Prime TV, which has content, they've got, I mean, they have all the pieces there, and all they were missing was a physical and in-person way to connect with patients. One could have argued they could have attached this to Whole Foods and gone like the CVS Minute Clinic route or the Walgreens Village MD route, but I think or even Walmart with their Walmart health centers. But I think like that to me is what this deal is all about, is just getting a physical footprint so that they could have a way to interact with patients, you know, face to face if need be, to support all of those services. It was just the last piece of their puzzle. And I mean, I think from the things I've read, you know, the highlights of One Medical are, you know, obviously Iora and what that provides for Medicare Advantage and working with that population of patients. But the other part of it is like the 8,000 employer contracts, and that Amazon Cares could not take off in this last year, because which employer wants to go along with that when they've got no real demonstrated use case, no real, you know, bodies in the market, no care delivery option other than telehealth. So, I mean, I think like what they got was that 8,000 employer partner book of business, a way to have a physical footprint in some areas in 25 markets, and like Lord knows they have the capacity to expand. And I mean, honestly, people are like, you know, what is it, 3.9 billion? It's like, that's a great deal. They paid $1 billion for PillPack. They paid like over 13 billion for Whole Foods. Like, I don't know, like they really, I think, got something that, like, whether or not that works, that's like a drop in the bucket for Amazon. So I think that's like, I mean, really, I mean, it makes sense, and it keeps them competitive with those other big retail health players. They had to do it. I really think they had to do it.
Jess, are you going to be a subscriber?
I would love to. If they can come up with like a more unique payment model around this, like a package, I would totally, because I loved way back when Oscar Health launched. I was like, I had that health insurance. I bought it on the exchange. And the thing I loved the most about it was the virtual component, but the fact that if I needed to go for an appointment, the network was right there. Like, I liked it, but it was just, I mean, it streamlined everything, and it made everything very simple. And I think that's like the Amazonification of anything, is like this way to kind of realign the supply chain and the business model around things to create a little bit more compelling value, make it more convenient, more easy, and like something that you can get at a press of a button. I would totally subscribe to that. I was in fact looking at a female primary care clinic that has physical locations. I just moved. I was looking to see if what insurance they take, so that I could redo my plan, so that I could go to one of those specialty little women's health kind of clinics. So yeah, I'm in.
So here's the question that I'm asking you. Amazon already had a strategy for a physical footprint with their collaboration with Crossover, which is I really like Crossover. I think
I do too.
there's a, you know, it's a hybrid model. It wraps around physical locations. They were obviously focusing initially on their own 1 million+ employees and trying to create a delivery system for them. But I guess, you know, that further movement into acquiring physical assets and physical locations was the part that kind of threw me. And I think, you know, Amazon began as an asset light model, where what they were adding was access to the world, access to all this stuff that you could buy. And then they began adding assets. They built this enormous physical distribution infrastructure. Then they built their own fleet of trucks. Now they're starting to have their own airplanes, and now they're going to have their own thing of clinics. And you know what's been happening all the way along? Their return on assets is going down. So that asset light thing that everybody loved about Amazon is going away. And I mean, how do you square, you know, where the real leverage is, which is what you just said, the ability to connect you up to solutions, with the idea that you're going to need physical assets all over the place, not in 25 markets, but in 200 markets. Where's the return to the shareholders of Amazon from that strategy?
So there are two great themes out of this, right? One is for Amazon and these big players, like, you know, can they make money? And because the other thing no one wants to admit about primary care is the way we run primary care, even with the people who've had full risk, you know, but certainly for the average fee-for-service primary care doctor, which is still what, 80% plus of them, those are incredibly low margin businesses, right? If they are businesses, right? So now he's saying, great, we're going to get into one. They have fancy waiting rooms, and I'm a One Medical member. I'm almost too ugly to be allowed in the waiting room, but I slip in under the bar. That's quite a high bar for that,
Matthew.
Sorry?
To what?
Exactly. But I mean, but I guess that's one issue. Is can you make money in primary care? Because so far none of these online, none of the primary care groups that are public now have. And if you go back to the 90s when I met Jeff, none of the primary care groups who went public then could make money either, right? They all went out of business. So that's one thing. The second thing which I want to get into is this whole issue of how does Amazon come into a market? There's a great chart which I put on yesterday, which shows sort of Amazon's stock price and market cap in 2006 compared to 2016, compared to like JCPenney's and Macy's and Nordstrom's and what else, right? All those companies effectively they're destroyed by upending retail. And my assessment was, if you looked at crossover, you looked at like a company like Everside, which used to be Paladin, which has raised a ton of money this week. Their goal was to go to employers. This is kind of the Brian Klepper we often have on the gang approach. Go to employers, build an insight work clinic, a bit like crossover is doing. Stop the employers, narrow the network the employees are going to, and essentially do a sort of mini Kaiser inside the workplace. And then with that, reduce the cost of overall care. And a lot of people have done that on a small scale. No one's done it on a big scale. But obviously what that does is it poses a threat to the standard healthcare system, which has big health systems that bought up primary care, that use primary care for referrals, make money, or the big systems where all the money lives. And Jeff and I go back and forth about this the whole time. The big system where all the money lives in American healthcare, and start stripping it out from that and reducing the amount of usage, et cetera, on that kind of capitated primary care model. I assumed Amazon was going to go down that path and sort of go at risk, a little bit like some of the teeny companies who are in the space who've been in this summit, like the crossover a bit, but also like the Firefly Health and some of the others are going down the path of. So, I mean, is anyone else surprised they decided not to do that, and instead to go to double down on more of a sort of fee-for-service, traditional but nicer primary care clinic? And where do you think they're going to take that?
I'd sort of agree with that angle in that I think it's probably one of the more interesting sort of untried opportunities with a slightly different spin. Like, to your point, the idea of narrowing networks has certainly been tried and often not succeeded. But what I don't know has really been tried, whether it's really been tried, is actually embedding information and steerage into primary care for the commercial population. So the opportunity, the idea of the savings available from adjusting utilization in the commercial population is lower than in the Medicare population, but from steering between different specialists or different hospitals is much larger, because you have these huge discontinuities between the prices of different facilities. And I don't know that anyone has really leaned in actually setting up the primary care as sort of the cockpit and trying to steer patients smartly to different choices for specialists or lab tests or radiology, that sort of thing. What I would say is, at least outside in, I think crossover to some extent is much better set up to do that. One, right, because they're not, as I understand it, primarily fee for service in their core primary care. They're capitated in various ways by the employers. And because they don't have these sort of back end deals with the most expensive slices of the commercial delivery system. So I had some of the same. That was one question I had, which is, to some extent, maybe that is an indicator that Amazon has a different thesis on this, that they're really looking at, say, online to offline integration between Amazon Care and One Medical, and One Medical has probably a larger clinic footprint, particularly if combined with the Iora clinic footprint, than a crossover or another asset that might have been available.
Dan,
yeah, I do a theory about this, by the way, which I said, which was that maybe Jassy said, go out and buy me that really cool primary care group that starts with the letter O, and they bought the wrong one, and they went to buy Oak. I don't know, Oak Street. I'm kidding. All right. Sorry, Jeff.
Wait. What's that? What's to say they don't buy someone else? What's to say they don't take out crossover too? I mean, this is the thing about them, that I think they're like, I mean, They're a gigantic business, and this is really nothing as far as an investment goes. If they want to throw another 7 million, make it around $10 billion like into this, they could acquire several other virtual first primary care clinics with a side of digital mental health on their own EMR IT infrastructure that provides, care navigation in a value-based design. They could have all of that. They could have them all. What stops them?
Jess got her to DAR slide in there.
Jess, if you think about the hundreds of companies that are operating in this space, there's really only 4 or 5 buyers for them.
Right.
It's a really small universe of potential buyers. And the issue of what business model or what allocation of risk works to float, the acquisition prices of these things, that's the real question. One Medical was not a managed care company. It wasn't a managed care company. They weren't trying to optimize the flow of patients through the system. They were trying to milk the existing system for as much as they could get. And when subscriptions wasn't enough, they started marketing to employers. And when that wasn't enough, they started billing people. And then after that, they started shaking down health systems for the referrals. That wasn't a business model, guys.
Shaking down is not a business model. I think the mob ran that way.
It's not a defensible business.
Okay, hey.
Okay, it's all I'm saying. And I'm just like, I'm having trouble figuring out. Healthcare is a $4.3 trillion business. It's 20% of the economy. So if Amazon wants to be a major player in our economy, they're going to have assets and a presence in this space. But the issue of who are you generating value for besides your own shareholders is really elusive here. And I think, they could buy half of the companies that you've been following and still not have a business. You see what I'm saying?
Yeah. Well, I was going to ask you this is like, even to hear you talk about, the way primary care works within like the traditional system and attached to a health system, shaking them down, so to speak. Could Amazon be looking at primary care the same way? It's like primary care is a loss leader. Like in a grocery store, it's like, I'm selling the turkey for this much lower per pound. So you're going to come in and buy your booze and your pumpkin pie stuffing and like all the other stuff to go along with it. If you put this in the Amazon world, this is just one thing that now you're going to buy. Is that how it works? Is this it? Am I missing that?
Unfortunately, their retail business is within an eyelash of being a loss leader. For Amazon Web Services, the really profitable part of Amazon and the place where all the profit growth is coming from is from leveraging their infrastructure, not from delivering stuff to my house. So if that's the way they're going to approach healthcare, boy, oh boy, I'm shorting Amazon stock tomorrow morning.
Well, you should have done that last year, like me and the rest of the stock market. Shoulda, woulda, coulda, shoulda. So let's push a bit more on the rest of it. So there are a whole bunch of, and Dan, I want you to say a word or two more about, Pine Bark and your sort of market selection. But if we shift away from Amazon One Medical for a second, which I think confuses us all a little bit, but it's not the let's build the Kaiser of the 21st century. There are a bunch of people who are trying to build the Kaiser for the 21st century. They're trying to build the primary care based with new technology, with virtual and remote and all the rest of that stuff, but targeting expensive people and trying to reduce the cost of care. So we mentioned Firefly. Dan, obviously you're doing that with a very specific population. There are, and I mentioned Everside, who raised money from NEA and Oak yesterday, a couple of days ago. There are a lot of approaches to this. You could argue crossovers in that boat as well, even for sort of higher end groups. And Oak Street, of course, is somewhere in there. IORA was, all these different populations, ChenMed, et cetera, et cetera. Almost all of those companies, all those primary care companies, are being featured, somewhere in the summit that we're part of. And almost all of them are, it sounds fantastic on paper. You hear Rashika Fandanopoulos explain how, they spend twice as much on primary care and save 30% overall. They never made it to a profit. Mentioning crossover, they bought our pal Jay Parkinson's a company Sherpa, which was the online part. They wrapped into that now. I know Jeff had me and Jay come to talk to his group in Charlottesville in 2008, 9, 10, a long time ago. But none of that stuff has really changed the big world of how we do primary care. So I'm wondering, there are another group of players, right? So which include the biggest players in healthcare. But I'm thinking here, Optum, not Anthem, what's it called, Elevance, and
Yeah.
the Signals, those guys who are slowly moving in, right? Signal bought a telehealth company, and they're also chomping around the bit. And Optum has bought a lot of physician groups, right? Dan, Jeff, I'd love you to make a bit of sense to me about how you think the overall transformation in space is going. And could we see the kind of thing that perhaps we're not going to see from Amazon while they're just more medical, but who might be the 21st century Kaiser? And is there a way you can make it virtual, integrated, capitated, make it spread, and make it cheaper? Or are we delusional here? Or am I delusional?
Well, I mean, the big difference between Optum and the slew of businesses that Amazon is fiddling around with is that Optum generates a 9% operating margin on this enormous care system. And for better or worse, they've bought some of the most tightly managed, thoughtfully constructed, at-risk care delivery systems in the country. Atrius, that they're going to close on here in a few weeks. Healthcare Partners. I mean, you look around the country, the Everett Clinic in Seattle, it's a really elite subset of the total care, primary care and physician system in the country. So, I mean, there's decades worth of road miles, if you will, to mix metaphors, in Optum's system that does not exist in Amazon's. And I don't know whether it's a system or not. We can argue about that. I don't know if it's Kaiser or not. It's an asset light model. They don't have hospital beds. They don't have all that overhead. So, I mean, if I'm a betting man here, dude, I'm betting on Optum in this. And they've got twice as much money to spend on this stuff as Amazon does.
I don't necessarily have the same view. I think when I look at Optum, I see them mostly buying up incumbents, some of whom are tightly managed and certainly stand out in their local markets. I did probably agree with your assessment of Atrius, but I also look at a lot of what Optum's bought in Southern California. And I think these are really the archetypes of 90s style managed care.
Okay.
I don't know that most Americans would look at the assets that Optum has assembled in some markets and hope for that future of healthcare.
Okay.
I think to some extent, and I think it's really hard, maybe impossible, to really compare margins between Optum as represented on the UHG 10K and One Medical, or for that matter, Oak or anybody else, right? What I do think is different, and I think is just a sort of break in the strategies, who you're trying to serve, and then what is the viable financial model for doing that, right? Primarily, Optum is serving, or at least the bulk of their risk likely, and the revenue that they show on the P&L is coming from Medicare and to some extent Medicaid or duals, that where they're globally capitated. It's probably more like Oak Street than it is One Medical.
Say a bit more about the comparison between the margins, of One Medical and Optum. Do you think Optum is hiding that it's not doing so great in the margins of, like the Health Partners asset or the Everett, or the assets compared to, they just bought that big one in Houston as well, right? Kelsey-Seybold as well.
Kelsey-Seybold.
I mean, do you think and they're hiding it because they're making so much money, the other tech stuff buried within Optum.
It's not so much that I think they're unprofitable. It's just that I don't know that you can really compare sort of the margins as reported. My guess is the biggest difference is if you buy Monarch or Apple Care, or for that matter, Atrius, right? You're buying a single sort of market, single location care delivery organization that's already operating at scale. And I think one of the biggest factors that you see in the sort of aggregate P&L from a One Medical, but also certainly, and probably even more so from an Oak Street, is you really have to separate out the margins that they're generating on their scaled up markets and clinics, where they already have 2,500 plus patients going into one clinic, and the new markets, right? So you look at Oak Street's gone from 0 to 25 plus, I think, states over just 5 years. None of the assets that Optum has rolled up has done that. What they've actually done is just build up scale in a specific local market, and then Optum as a financial engineer has come in and put them all under one umbrella. That's not the same thing as trying to go into new markets organically, where you have to build a clinic, hire a staff, and then build a panel, right?
Yeah, that's right. I mean, that's actually very much what I thought that Amazon was going to do, right? I thought they were going to do all of this organically, do it start with add a crossover to all of their
Well-
to their warehouses and then go from there. But they don't seem to go down that path. But
Well-
but what do you think? I mean, what do you think about the prospects? Jeff, I'd love your view on this, and Jess too, of these extremely asset light. If I go back to Faye Rotenberg and Jonathan Bush talking about Firefly, they're really talking about and this is actually was you go back to Jay Parkinson's Sherpa, it's 80% plus of the stuff being done virtual of the commercial population being done virtually, and then you wrap around stuff that happens in the home, in the apartment, or wherever. Bit more for the seniors, but then you can add in a sort of at-home visit, and you can do all the you can build those pieces up. Is there a prospect of building a primary care thing that looks like a primary care plus chronic care management of the sort of relatively healthy seniors? Is there a prospect of building a national platform for that?
Boy, oh boy, I don't know. I mean, I'm one of them. I'm 73. I've been in Medicare Advantage for 8 years. How much of an enticement would it take for me to abandon the primary care doc that's taken care of me for 20 years and subscribe to some subscription service where I'm talking to some person sitting in Flatbush on my phone? I mean, lots of luck with that. I really believe that, reaching folks like us I've had a brush with cancer. We've talked about that before. The risks for me are way higher than they are for someone like Jess, who's radiantly healthy. The amount of trust required for me to establish a relationship in the care system is a whole lot higher. So it isn't a question of a slick interface or the fact that you've got, 30 markets or 200 markets. It's who do I trust to manage my problem, and who's going to know enough about my problem to give a crap the next time I get cancer. So I'm like, I'm in the demo that you just fingered, and it's going to take, I would have signed up for One Medical if it had been here in Charlottesville 20 years ago. I'm not going to sign up now. I'm not going to talk to Alexa about my healthcare problem. He's going to say, oh, go sit on your toilet and we can evaluate your medical situation by, biological whatever. I'm not going for it.
I'm a bit more optimistic, but I guess I think of it in a more kind of structural way, which is to say, when Jay talks about Sherpa and the 80%, you always have to keep in mind the selection effect. That's not a random draw from the population, right?
Yes.
That's people that chose that model. And one challenge you always find, and this is, for what it's worth, this is true for Pine Park as much as it is for a virtual care primary care company. For some material chunk of the interactions, you can't avoid the incumbent healthcare system. Right now, it varies what exactly. Maybe it's a referral to a specialist. Maybe it's the lab test that has to be done in person because it requires a blood draw and a cold chain for the specimen. These examples, right? Radiology. So I think when you look at those lightweight layers, I suspect can do a larger fraction for the commercial population, because most visits are quick check-in, maybe a script. And the lab test, while often requiring physical interaction, is probably the most solvable part of that interface between online to offline, because you have Quest and LabCorp as scaled up options, largely nationwide with their own sort of distribution. I think it gets harder as you get into kind of needier populations. And I don't mean that in any pejorative way. I just mean people who, as they age or because of conditions that they've been unlucky enough to have, need more regular and more intensive care. Then a larger and larger fraction has to happen in person.
Right.
And then it requires more investment in physical infrastructure and more breakdowns when the service experience has to move offline. And I think that, to some extent, to bring it back to the beginning of the conversation, that was one of the things that struck me as maybe the most interesting angle, because Amazon does have form in online to offline. Building up that distribution for same day or next day delivery is an incredibly difficult thing, right? Building up the footprint of AWS data centers, right? And they do have some ability to deliver a pretty seamless online to offline, even with a distributed workforce, as they do have with their drivers. And so you can imagine this actually fitting with some of their core capabilities over the next 5 or 10 years, right?
Dan, just for Pine Park, how do you, is there an offline component, or are you essentially a mobile primary care group that centers around, centers around assisted living and other places like that. I mean, is how much do you get into the rest of this stuff and the management of the overall experience of the patients, and when they go out to the specialty care, are you following them around and tracking them? How much of the philosophy of that is there? And the other question is, are you converting people like Jeff from their previous experience to a new organization?
Yeah. So last question first, we definitely are, right? Seniors, when you look at the numbers, 90+% of them already have some primary care relationship. In practice, that varies from close and committed to very loose. I saw them once last year, that kind of thing. But yes, we are seeing very high adoption rates. When we go into senior living communities, we often see as many as half of the residents who can sign up for Pine Park, given their health plan, do sign up for Pine Park, right? Which is a pretty high conversion rate if you think about it. But, and most of our care is in person. I'd say something like 85% of our encounters with patients are in person. Now, we don't have the physical infrastructure. We don't need it because it's mobile, right? We're shipping, our clinicians are going around and visiting people in their homes, usually with some small kind of operating base within the community. But that doesn't free us from the same challenge that bedevils a lot of the virtual players or virtual first players, because those patients also need lab tests. Sometimes they need colonoscopies. They need imaging. Sometimes we need to see a cardiologist. Sometimes we need to see a behavioral health specialist who may or may not be set up for closed loop referrals, who may or may not be mobile, who may or may not be able to share data the way we would like to with families and patients. And who may or may not have open access scheduling, so we can't get them in for 3 weeks, right? All of these challenges that you get from traditional sort of incumbent providers don't go away. I think we can do a little bit more and do a little bit more. We do some of our own phlebotomy, our own lab testing, right? Somebody has a UTI, we send somebody to go collect the urine sample, we run the assay. But we can't do that for everything, right? So we still run into some of the same challenges that I think can frustrate or cause breakdowns in the virtual first experience.
Interesting. So I'm going to ask you, we're down to our last 3 minutes here. So just a minute from each of you, or 30 seconds from each of you. When we talk about, when I grew up in this business and I sat at the feet of Alan Hoban, and he explained to me how great Kaiser was and how it was going to take over the world in the late 80s, early 90s, and then we heard how great Friendly Hills was and Mulliken, they were going to take over the world. And now we have all these virtual first sort of primary care groups. Medicare one is partly traded, but as Jeff said, still stretching for a business model. If we were to push the clock forward 10, 15 years, do we think primary care will really transform? How different do you think it's going to be out in 2030, 2035 compared to the kind of the status quo of the big healthcare systems, still pretty much dominating primary care as a feeder now compared to all this transformation? So I guess the question is, how much transformation will there really be? Let's quickly go around. Jeff, I want to start with you.
I think the biggest barrier to transformation is going to be inability of our nation's Medicare program to do stuff that's simple enough that it doesn't make the problem worse. And to me, that's my challenge here. They're experimenting with, the direct primary care model. They tried to get, from 5 E&M codes down to 1, and they stopped at 3. To me, it's that legacy payment system that's really going to hold us back. My generation of primary care docs is going away. It's being replaced by people that are Jess's age or even younger. And it seems to me that it's the instrument lag in our payment system and our health policy that's really going to prevent us from getting to a responsive, activated primary care system that we all can trust.
I'll take that as a not much. Dan.
I'm an optimist here. I think primary care in 10 or 15 years is going to be materially better than what people experience today.
I hope so.
In terms of the patient experience, I think it can make a dent in the cost of care on the Medicare side. It probably cannot make a material dent in the cost of care on the commercial side. That's a policy problem. And I think my main ask or sort of suggestion for what I understand is the next speaker would be for CMMI to sort of adjust its theory of change, which is to say CMS tends to build programs around the needs and preferences and profiles of incumbent providers, that will not be the path to change. That's not going to be the source of better patient experiences or lower cost of care. You actually have to build these programs as on-ramps that encourage new players to come in, offer new homes for the clinicians that are already in the market, and that's how you get change. You can't expect legacy players to be the path to a fundamentally better system. It doesn't work in any industry. It won't work in healthcare either.
Jess.
I mean, on the healthcare consumer side, I feel like, it's what Jeff said. If One Medical had been there 20 years ago, he would have signed up. So it's like, here I am looking ahead 20 years. And it's like, I haven't had a traditional primary care doctor that isn't CVS Health since 2015. And even then, I was forced to pick it by my employer. I didn't even choose this person. I just needed to have somebody that filled in the blank so that I could continue on with other healthcare. Right now, I get my healthcare, like I said, from a CVS or a Walgreens, and for online providers. I like Ro, I like Hims. And it's like, I'm going to age into a system that I think is going to continue to move into an ever more omni-channel delivery thing. And whatever that looks like, I think that's where the transformation is going to happen. I think the delivery system is going to become a lot more, like we're used to with everything, online and offline. And then the payment model, like these guys have said, it's got to evolve along with it. I'm used to paying out of pocket for basically everything. Tell me more healthcare later.
All right, so we're moving to a cash-based online system. It's all going to work out fine. Right. Well, that is the end of the THCB Gang. I want to thank you all for your attention and listening. THCB Gang usually is available on the healthcare blog. Check us out on our Apple, Spotify, where we get your those two podcast channels. The THCB Gang, you'll see Jess's and my Health Tech Deal show as well. We have had today Jessica DaMassa from the cool 107 degrees of Phoenix, Jeff Goldsmith from Charlottesville, Virginia, and Dan O'Neill from somewhere in the Bay Area, I'm not entirely sure where, outside. Thanking you. And now for the rest of the summit, we're going to turn over to Francois de Brantes, who is the chair for the day, who will be introducing Liz Fowler.